So the next session we will talk about the first topic. We invited our general secretary, Dr. Wang Chen-Ying, give us the talk about with post-cervical heritage in cervical incompetence. We know the cervical incompetence is very difficult to treat because some patients have a cervical incompetence. He have no obvious sign of genital sign, but sometimes the patient have cervical incompetence almost can happen the abortion. So sometimes we need to prevent it. So we created this speech, and so we give this speech by Dr. Huang, please.
Thank you for your kind introduction. And good afternoon, ladies and gentlemen. I'm Huang Chen-Ying from Chengde Memorial Hospital. Today, I would like to share our experience in treating cervical incompetence by abdominal cerclage, either pre-conceptually or post-conceptually. Cervical insufficiency, by APAGE definition, is inability of cervix to retain a pregnancy in the second trimester without uterine contractions. And we would diagnose this kind of problem either by history, like if our patient got more than 2 consecutive preterm loss between 14 to 27 weeks, or by sonography. If our patient got 1 preterm labor less than 34 weeks, plus we measured her cervical length less than 25 millimeters before 24 weeks of gestational age. Or when we do the PV finding, we found her cervix got dilated and effaced between 14 to 27 weeks without uterine contractions. The incidence of this problem is quite low, but however, it may become tragic outcomes of our patient. This problem either by congenitally, if our patient have some congenital anomaly, or by acquired, such as trauma by the previous delivery with forceps or vacuum, or rapid dilatation of previous pregnant, or cervical colonization for skin lesion. And overall, the treatment, we can choose conservatively bed rest, which is not effective enough for our patient, or medical treatment with progesterone, or surgical treatment with cervical cerclage. And this is the flow chart assembled from the previous knowledge. So we can see we would survey our patients if they don't have previous negative pregnant outcomes, and they don't have high risk history. So we would evaluate them at around 20 weeks of gestation to survey their cervical length. And if their cervical length less than 25 millimeters, we could prescribe vaginal progesterone. But if our patient is high risk patient, so we would make our survey earlier, around 14 to 27 or 28 to 36 weeks. Then measure their cervical length, and we would state the surgical treatment for the last concern. Then, if we would choose the cervical cerclage to our patient, most commonly we would take transvaginal route as consideration, including McDonald method or Girard card. And we will dissect both anterior and posterior vaginal mucosa in order to make our suture more closer to the internal os. However, according to the paper published, there is no difference in the pregnancy outcome between these two different routes. Then the timing we concern to give our patient transvaginal cerclage. We can take history indicated, or ultrasound indicated, or the patient is coming with obvious symptom signs, and we can find by our physical examinations. And so we would like to emphasize the position we put on our cerclage is a bit different. In McDonald method, usually we would just traction in the cervix into vagina and just put the suture here. And chirurgical is a bit closer to the internal os. And transvaginal cervical isthmic cerclage is more closer, like more inner than the cardinal ligament here. And from the transabdominal cerclage, we would try to put our suture exactly in the internal os, in the isthmic area. So what kind of patient we would consider to do the abdominal cerclage? Usually with patients with previous failed transvaginal cerclage, or when we do the pelvic examination and found their cervix is extremely short or amputated, so we are unable to undergo the transvaginal cerclage. And we use the 5mm Merceline tape, the same like McDonald method we use in our daily practice to do the abdominal cerclage, which is a non-absorbable grade polyester suture, and it's non-reactive and it has incredibly strong content. So here is a paper which concerned the transabdominal cerclage, when we should put the cerclage, either preconceptually or in the first trimester. So they got 65 patients and 96 patients preconceptually. As we can see the surgical outcome, it seems there is quite safe and almost no complications in the group of preconceptually group. And the pregnant outcome, it looks like favored preconceptual group 2. It has significantly difference. So they analyze what could be the reason to have better pregnant outcome in the preconceptual group. We can see in the procedure we can have optimum exposure of the cervix and eliminate the risk to injure to the pregnant fetus. And there is more patients can have more than 34 weeks delivery, fewer serious surgical complications. However, we may need to explain to our patients there may be risk. They cannot go on to have pregnancy, like up to 1/4 of the patient, and maybe they have higher risk to have subsequent fetal demise. And when we do the post-conceptual cerclage, we can exclude the fetus of major structural anomalies by ultrasound. And we can gather information from early aneuploidy screen for this fetus. However, when we perform this kind of surgery, because the enlargement of the gravid uterus, it is quite challenging to perform the procedure laparoscopically after 15 gestational weeks. Then this is the common way we would deal if like our patient got unlucky after cerclage have fetal demise. Then we can share how to do the procedure with the abdominal cerclage. In the old ways, here are the uterine arteries here, and we would try to put our sutures inner than the uterine vessels, and fix it in the internal os in this area. And we can show the video here, which performed robotically.
A bladder flap is then created.
And here the surgeon is creating the bladder flap and open the window here, lateral to the uterine vessels. And this is a case of preconceptionally.
The stitch is then placed into the uterine artery at the level of the internal cervical os.
And we put the tape with the suture inner to the uterine vessels.
Although this video shows the robotic approach to a minimally invasive abdominal cerclage, these same surgical techniques could be replicated with third-stage laparoscopy.
And before pregnant, we can manipulate the uterus pretty well with the uterine manipulator, as this video demonstration. And we are going to show another video which compared the difference between preconceptional and post-conceptional procedures.
Now we will go over some of the differences between conceptional and preconceptional techniques. In the non-gravid regions, the uterine manipulation can help with manipulation, visualization, and exposure during the procedure.
So, here is the non-gravid uterus. And now show the pregnant uterus.
A sponge stick in the vagina is what can be used.
And they only use the vaginal gauze inserted into vagina to elevate the uterus a bit. And
preconceptional cerclages, access to the broad ligament to develop the windows is much easier, and these windows are developed with minimal bleeding. In gravid uterus, however, access to the broad ligament is rendered more difficult by the through manipulation, the size of the gravid uterus, as well as engorgement and dilation of blood vessels.
so it's more difficult to isolate the uterine vessels and create the window. And as we can see, it usually has more blood loss during surgery. And because we cannot elevate the uterus,
Non-gravid uterus, it is easier to visualize the uterine artery and skeletonize it with minimal bleeding force. In a conceptional transabdominal cerclage, the uterine veins are engorged and in close proximity to the uterine artery, which makes skeletonizing the uterine artery harder. As you can see, the conceptional cerclage, the vascular bundle is more engorged and wider than the preconceptional cerclage.
okay. So is there any difference between laparotomy or laparoscope route to perform the abdominal cerclage? Of course, we know we will have shorter hospital stay, less pain, rapid recovery in the laparoscope group, but we concern more about the success rate and the complication rate. So here is a paper from 2018, and they analyzed the two groups and found that actually for the pregnant outcome, the group of laparoscopy is a bit better than laparotomy group. And the complication rate is also shows similar, a bit favorable on the laparoscopic group. So how would we perform in this way? And of course, with the robotic introduction to our medical practice, there is also some doctors can perform this procedure in the robotic way safely and with physicality. Then there is more update data compared both preconceptional and post-conceptional in laparoscope and laparotomy to evaluate their outcome. And the analysis all these papers here, including 11 series of laparotomy and 3 series of laparoscope. Overall, they think the pregnant outcome is similar in both groups. And the failure rate is also similar. Except that in the post-conceptional cerclage, the laparoscopic group is less favorable in the pregnant outcome. And for the surgical complications, we can see the laparoscopic group has quite good performance, which has fewer and less surgical complications. So in conclusion, the abdominal cerclage performed via laparoscope in non-pregnant women is preferable. So what's the difference between the procedures? When we put our knots, sutures, anteriorly, we may concern bladder irritation, pain, and hematuria. From posteriorly, usually we would put our sutures, ties posteriorly in preconceptional group patients because we can remove this suture from colpotomy to allow vaginal delivery when our patient got turned pregnant. But they may cause some adhesions in the cul-de-sac, and it is more difficult to approach during pregnancy. And the surgical techniques, in previously, we can see the pictures as we shown before. The ideal suture placement is medial to the uterine vessels. However, recent years, more and more surgeons would prefer modified this procedure to put the sutures laterally to the uterine arteries, and they claim that it's still the comparable pregnant outcomes. And here is our group published a paper, share a case experience. When she got she has poor pregnant history before. And firstly, we have done the laparoscopic cervical cerclage for her when she visited our OPD around 15 gestational weeks already. So we did this procedure to rescue her for the emergent cerclage. And we open the bilateral windows here and tied. However, this pregnant still got fetal demise. So she had termination of this pregnant. Then after recovery, we decide to perform another cerclage for her. So we still choose to do it laparoscopically. And here we open the tunnel and adjust the sutures and more tightly and fix with the hemoclip posteriorly here. Then after 1 year, she got full-term delivery. So we collect our data from 2010 to 2016 with the indication of previous failed vaginal cerclage or by PV findings. There were 29 patients with 31 surgeries because there are 2 patients got 2 surgeries. The timing of the surgery, we have 23 patients preconceptually and 9 patients post-conceptionally. And we collect their previous pregnant outcome. Totally, they got 45 pregnancy before, without 27 times without vaginal cerclage, 27 times with vaginal cerclage. But among 54 pregnant, the neonatal survived outcome is pretty poor. Only 5 babies were alive. Then we perform the procedure for them. The mean operation time is around 70 to 100 minutes and minimal blood loss, no complications, and fast recovery. The pregnancy outcome in the post-conceptional group, we got 1 patient lost follow-up, 1 IUFD at 28 weeks, and 1 twin pregnancy. And we can see the neonatal survival outcome increased to 85% here. And 2 of them got pregnant, can continue pregnancy more than 2 term. For the preconceptional cerclage group, we have 2 patients lost follow-up, 4 patients could not get pregnant after surgery, and 3 ongoing with spliced ovum and got BNC. And we can see the neonatal survival rate of the preconceptional group is also very promising, almost reached 86%. And most of them, 8 of them can reach term pregnant. And the birth weight of neonatal birth weight is around 2,000 grams. So in our group, we have quite high success rate from the previous poor pregnant outcome, 9% increased to 85%, either preconceptionally or post-conceptionally. So in conclusion, the preconceptional laparoscope approach for the cerclage is preferred from the literature review, and the success rate is quite promising, up to 85% to 100% in different groups. And in our groups, in our way, we can achieve the pregnant outcome in an excellent way, almost 86%. Thank you for your attention.
Thank you, Dr. Excellent speech.